So, 25% of the eyes causing less than 20/200 vision. And open globe injuries, it can be related with 10 to 41%. It was 7 minutes, I think, when I started. Can you arrange? At the time. Okay, the most frequent is the metallic foreign bodies. So, can you? Oh, sorry. Okay, I'm fine. Thank you. Okay, thank you. Okay.
Okay.
So we have to suspect in
Dr.
summary
Nur,
every open globe trauma for the
it's coming
foreign
now.
body, and we have a detailed history and also detailed examination started from the cornea, conjunctiva, iris, and lens, and we have to search for entry sites, possible entry sites, and imaging is necessary to manage the patient also. CT scan without contrast is the best option for scanning, and the sensitivity is really high. Should we remove all the foreign bodies if we detect? Yes, because of two main reasons. Because of the traumatic endophthalmitis risk is high, and with viral and microorganisms, and with the toxicity risk for the metallic foreign bodies, which are the most prevalent ones. But sometimes there are always exceptions. It's a chronic foreign body, old foreign body, and visual acuity is really high. We can discuss it with the patient and follow up, but the follow up should be with ERG, and the B wave amplitude we should always check. If it is less than the lower 50% of the other eye, it becomes visual decrease becomes irreversible. So we start the prophylaxis, tetanus shot is given, and when to remove the foreign bodies is another discussion point. If the patient is systemically stable for the anesthesia and for the surgery, is if there is active infection, and if this surgical team is necessary, then we go for the early vitrectomy, primary closure, and including the foreign body removal, if we can do that. But if not, we should close the wound and then plan, be it ready the patient and intraocular foreign body like 2 to 7, 8, 10 days. There are some especially rules in this, because we have to check all the wounds that may be still open and leaking, because hypotony is something that we don't want in these eyes, and we have to we can start with the longer cannulas, infusion cannulas, anterior segments, anterior chamber cannulas. We can start with the surgery, because we should always see the tip of the infusion fluid to avoid choroidal infusion or bleeding. So intraocular removal of the foreign body depends on the size and the magnetic properties. If there are small magnetic ones, we can remove with the magnet, or we have a lot of kind of forceps, and even the snare loop is defined for the large foreign bodies. From where to remove? So if it is the shortest length is 5 millimeters and longer, then we should prefer the corneal site, because it gives a lot of damage to the scleral site, and we want to remove it with the greatest control and with the least surgical trauma, and from the possible smallest exit sign, like this one here, for example. It's really a large foreign body, almost maybe 12 to 13 millimeters long, but it's a slender one. So with the bimanual thing, through the access with the minimal exit area, we can remove it, and the visual acuity remains 20/20. So for the smaller ones, this is a magnet removal. Sometimes I like to open another wound, because not to damage the trocar area. As you can see, the magnet you can lift and put it into the iris, but sometimes it is stuck. You need to go with the forceps and remove. So this is another example of a surgery. So I would like to show from the beginning. I sutured the wound because it's a leaking wound already. The eye was a bit hypothonous. We should always check. We can use the long cannulas, start from the anterior chamber, and then posterior hyaloid in these young patients. Sometimes it's not easy to remove at once, so we shouldn't we don't push so much, but we can lift a bit. As you can see, it's not removable easily. So if you wait, you can release some vitreous removal from the periphery, and then with time it is the attachments get loose in some minutes, and then it is easier to with active aspiration. As you can see here, the posterior hyaloid. We always protect the macula from the inadvertent dropping of the foreign body. And as you can see here, peripheral vitreous removal is really important. It's a must because there are some breaks that we can miss also sometimes. And this is already a traumatic cataract with the anterior to posterior loss of the capsule and the zonules. When we take out the cataract, so the zonule particles should be removed because this is a need for PVR formation later on, or hypotony. We can have a very nice eye with the attached but with the hypotony. So we should remove and do the cleaning as much as we can. And at the end, as you can see, the diaphragm is really important, as already mentioned very beautifully. With the Sipser suture, we close the anterior segment, and then the silicone oil. The eye, there's always a secondary chance for the eye implantation. The eye really went well. So what are the new design forceps? Because of the large and like glass, very difficult to control and to protect inadvertent falling to the retina, there are two new forceps, which one of is my design from Teknomek is producing in Turkey with the nitinol loops, and the second one is claw forceps 19 gauge from India with Natarians and group. So we have these options. I just want to show that's a severe eye trauma starting, and then we can see the air gun pellet, like this is larger than 5 to even 7 millimeters long. It's a big one. So this is how the forceps is working. You can enlarge and get tracked, and then you can get out the foreign body. And when you have it, you cannot lose the foreign body. So this is how you can remove. You should close and then take it out. So sometimes we cannot see, but the foreign body should be removed, and we can have the option of a temporary keratoprosthesis. As you can see here, we put the keratoprosthesis, remove the foreign body, and then put again the same cornea. We can suture the same cornea in this eyes. That's an option. So prognosis is multifactorial, and poor visual acuity depends many factors like pupillary defect, relative apparent pupillary defect, large wound size, large foreign bodies, endophthalmitis, and PVR. But if the visual acuity is good at the beginning, that's a good sign. As a take-home message, it's a diverse situation, and the management should be adaptable, needs experience, because there can be a lot of surprises, complications during the surgery. We have to be careful, and it's good to know the composition, the location of the foreign body preoperatively, and the instruments with greatest control is nice to remove with least surgical trauma, and timely management with close follow-up can yield good outcomes in this young population. Thank you for your kind attention and patience.